Well, thank you everyone for having us today. I'm Glenn Gukin, and this is my awesome second year resident, Dr. Spar. I've been up here about 6.5, 7 years, and this is my first time getting to speak at the AAUW, so thank you so much. I was reading your mission statement that really resonates with me as a girl dad who talks to me about how much she loves her STEAM classes. I like that acronym that they add the arts to it. I was used, to the STEM growing up, and so to hear her talk about how much fun she has in those classes, being in the public school system here in Western Nevada County. I was going to talk a little bit with this, when we talk about trying to be interactive, of asking a little poll just with a raise of hands. Who has had a hard time getting in to see a doctor in Nevada County? Yep, perfect. So I'm trying to be a good patient myself as a doctor, and have been on a waiting list for about 8 months to get in with a primary care physician for myself, and got a call 2 weeks ago that the physician unfortunately had an illness, and so I was rescheduled. They saved some spots to April, so I got my new patient appointment out. Luckily, I do not have any acute health issues, just trying to be a good patient, but we all have that problem. So I empathize with you, and we are making this effort that we're going to explain a little bit today to try to help that shortage that it looks like the vast majority of us have experienced up here. So before we get into exactly what our program was, just to talk for anyone who doesn't know the basic kind of background of how a physician goes through their training to become a practitioner in their given field, is most of us do a 4-year pre-med undergraduate degree, followed by typically 4 years of medical school. You'll hear many of our physicians up here are allopathic or medical doctors, but doctors of osteopathic medicine or DOs have the same training as MDs, but they get additional training in manipulation of the spine and some soft tissue techniques that they do. So some of our most amazing physicians up here, some of my closest friends, are DOs and provide the same level of care just with an extra skill set to them. Our hospital chief medical officer, Dr. Hill, that we're so glad has joined the community, is an osteopathic physician. And then most doctors go through residency training of somewhere between 3 to 7 to 9 years. The 7 to 9 years people are the neurosurgeons and other masochists who don't want to think about leaving training. So for us in family medicine, it is a 3-year program to go through. And so we decided to try to address health disparities of a lack of access to primary care up here by implementing a rural residency program. Outside of the raise of hands that we all saw, there are other initiatives and disparities in rural health that have led to the need for us to do training in our area. Limited access to healthcare, specialists and subspecialists, and job opportunities. And the healthcare workforce shortages are prevalent throughout rural America. And you can see in a lot of rural populations huge health gaps just based off of geography. So a little history of our individual program that led us to kind of come here was in 2016. I was a second-year resident, just like Dr. Spar here, trying to decide where I wanted to go. My wife and I did residency together after medical school at Methodist Hospital in Sacramento, a Dignity Health-owned residency program. We had found it after interviewing up and down the state. I'm a transplant. I'm not a local yet because I haven't been here for 20 years. So, and being from Southern California, I liked it a lot up here, except for all the Dirty Rotten Giants fans. But other than that, I made peace with it. That's the one allegiance I will not give up, is my Dodger fandom. But so in our second year, I came up and did an elective at our hospital, rotating with a hospitalist group. And I went to the Wild and Scenic Film Festival and just really fell in love with the county, fell in love with the area, and was impressed by the scope of services at the hospital. So I gave a pitch at the time to Dr. Brian Evans and Mark Freitas, and they had taken my wife and I out for dinner, and I told them about a guy I'd met in Kansas City who showed me this model about rural residency programs. And there's a lot of data to support that if you train physicians in rural communities, they're more likely to stay in practice in rural communities. So I gave this pitch to him. Mark Freitas jumped on it, ran with it, got a consultation to see if we were eligible and appropriate to start a residency program. I signed on as a hospitalist with the hope to give a pitch to this program, and HRSA initiated a large set of grants to fund rural residency program developments because we're special, but we're not unique. This shortage of doctors is a national problem and most prevalent in rural areas. So we were the first cohort, they're now on their 7th round of grant services to fund these programs. My hope and opinion in that when we submitted our accreditation application was to find a mid-career sage family doc that was going to teach me how to do all of this and start the program up. We interviewed a few people but weren't able to find anybody. So we got accreditation with a different program director, but I stepped into the role and did some additional training to get us accreditation. In 2023, we matched our first class of residents that we'll go into a little bit with Dr. Spar and Dr. White. And we matched our second class this last March, and we'll find out about our third class of residents we'll find out again in March of 2025. We just received our continuance of accreditation, meaning we don't get audited from an accreditation standpoint for 10 years, which was a really big deal for us to happen. So the program's started off on the right foot. So, jumping into our first class of residents, who we matched was Dr. Spar and Dr. Kelty White. Kelty's not here today because she's in the hospital taking care of patients at the moment. And Kelty hails from Nevada County. Not that Nick isn't pretty cool, but Kelty's kind of our dream applicant. She's a Nevada County girl, born and raised up here, and we've recruited her to come and learn and practice in our area, hoping that the draw back to the area that she loves will make her want to train and then sign a job and contract here. They're both big skiers. She's also a mountain biker. She's been getting into the world of mushroom hunting. She loves dogs. She's got saltwater fish tanks. Every time I think I have a handle on all of her interests, she throws some other gem at me. And then Dr. Spar, I will let introduce, what do we have next? And I might also make him talk a little bit about his upcoming classmates.
Hi, my name's Nick Spar. So I'm from Beaverton, Oregon originally, which is right outside of Portland, Oregon. Grew up there and then moved to Iowa for undergraduate and stayed out there for many years. I wasn't initially considering pursuing a career in medicine, and did some work in the nonprofit sector for a while, and then eventually had that sort of spark, applied to medical school, went to medical school in Iowa, and then was planning to go to a residency program in the Pacific Northwest near my hometown. I did apply to one program in California and got the interview here, and then came out for my interview day and fell in love with the area, fell in love with the program, fell in love with the people who are part of this program, and felt it was something really special. So that's what brought me out here. I did my first year in Sacramento with Kelty White, and then we've been up here since July of 2024, so a little over 6 months now. And then we are really excited about our our next two applicants who will be joining us soon in July. So Carly, she's originally from Folsom, so right down the hill. She did her medical school training at Loma Linda. She's been very involved in harm reduction and community outreach while she was in medical school. Got involved in some pretty cool programs there, and is hoping to bring those interests up here when she joins us in July. And then same with Camille. She is originally from Morgan Hill, is also osteopathic trained in New Mexico, and has many interests. Her husband will be joining her when she comes up here. He's also a resident in emergency medicine. And so the two of them will be up here, and we'll have 4 residents in the community by July.
So I won't read this entire quote, but part of what made this project happen and help was Dr. Randy Longenecker came and did a consultation, came out. I remember multiple of you in the room had joined us we did a big kind of funny dinner down at a property in South County, and Dr. Longenecker was just so impressed by the community investment that made this program possible. And he talked about being very thoughtful about establishing our governance and embracing the community. And I've been just overwhelmed in support from the community about reaching out to either host our medical students when they're doing rotations, hosting traveling residents to come through, standing up for dinners, raising philanthropy for us to help subsidize a little bit of the housing when the residents come up, because our hope, it's a requirement that they have to live within 30 minutes of the hospital when they're up here for their second and third year. But my intention with that is that I want the residents to all live in the community when they're up here to see what it's about. Because we have a lot of physicians that do, and nurses that practice at the hospital that commute up from down the hill. And while it's a great hospital and we deliver high quality health care, it's not the same as living in the community and being part of the community. So I just really appreciated this quote, because Dr. Longenecker said that we had one of the strongest programs and one of the best evidence of community investment that he's crossed in consulting on programs across the country. So some things about our program that makes us kind of unique, other than having the best residents in the country, is our model. When I designed the program and we made it, when you were training a family medicine resident, a requirement is that they have to see a certain percentage of babies, a certain percentage of pediatric people, a certain percentage of women, a certain percentage of patients over the age of 65. And that becomes hard to do in some of our different practices. A lot of our family physicians that have kind of aged with their patient panel might not see kids anymore, for instance, or might not do obstetrical care anymore. So we opted for a partnership with Chappaday Indian Health to serve both our American Indian and Alaskan Native patients, but also the medically vulnerable of our population while the residents are training. And when this all happened and our accreditation happened, there was a little health event that went on. I think you guys heard about it, some virus that came through, and that made things a little bit challenging on some of the relationship building and getting things up and running. But our partnership has gone very well so far. So the resident physicians do their continuity clinic. They're required for 2 years to have a panel of patients that they manage as the primary care physician, and they do that at Chappaday Indian Health. And so Nick and Keltino are a little over 6 months in of managing their own primary panel of patients there. The good thing about that is it's service to the underserved, it's serving a vulnerable population, it's a really high quality run clinic. One of the bummers for me is when I meet people like you, a lot of people who might have commercial insurance who do not have Medi-Cal or Medicaid cannot be seen unless they're American Indian or Alaskan Native theirs. So there is that disappointment that I would love to be able to hand out Dr. Spar and Dr. White's business card to anyone in the community to have them see, but that is one limitation that we have a select panel of patients that they can see. But we just, you have to give them a good sell so that they sign with a different practice and move up here. So our mission statement is really focused on trying to train well-rounded family physicians in underserved rural communities. And I've also been pushing a big influence on our residents in trying to create not just physicians, but also physician leaders that are gonna either stay and lead in our community or go into whatever community they choose and be leaders and stewards of the healthcare system. I'll let you tell the layout a little bit.
So for our residency program, we do our very first year. The intern year is at our sponsoring institution in Sacramento, and so that's in Methodist Hospital, which is part of Dignity Health in South Sacramento. And then we work with a clinic there, part of the residency program that Dr. Gukin graduated from originally, and so they have a long-established residency program, family medicine down there, and so we're sort of integrated into that program during our internship year. Once we complete our internship, then we come up here for PGY 2 and 3. That's our second and third year of residency, and that's when we start seeing patients at Chappaday. We have a continuity clinic, so we are in clinic at least half a day every single week, and then we are also doing rotations at Sierra Nevada Memorial Hospital, and so we end up rotating through different specialties and working with physicians in different specialty groups. Every 2 weeks, we're transitioning to work with another specialty group. And so that includes our obstetrics physicians, our cardiologists, our orthopedic surgeons, et cetera. So that's what the official name of our residency program is the Dignity Health Methodist Hospital Sacramento Sierra Nevada Memorial Hospital Program, which is a mouthful, but it combines both our sponsoring institution and our rural institution here.
So this photo, I love. Nick and Kelty sent it to me, I think in their intern year. I think this was, Kelty is a trooper. She, chasing her dog down a rock that had slipped, fell and had a very nasty surgery requiring fracture 6 weeks into her intern year down at the South Yuba. So she got to experience our hospital in real time and meet a surgeon within her first 2 months of training. I don't recommend that. So I think this is her first ski trip after the injury. So, and yeah, this photo made me very, very happy. And most residency programs and physician groups are trying to focus on wellness and keeping physicians healthy and things like that. And so different programs do different approaches to wellness. Sometimes they'll say, on your lecture day, the fourth or fifth Wednesday of the month, you'll have a wellness day. Dr. Spar and Dr. White have requested that wellness day be flexible so that if there's a, what is it called, Bluebirds Day? Yeah, a good ski day, a powder day. All right, I don't speak the language well yet, so he'll give me a hard time about that later. But that they can get out on the slopes, which I love. And I won't go too much into this, but something that just really made this program possible was the investment. And you can see it's a little dated because unfortunately Yuba Docs does not exist anymore. But the community partnership and buy-in has been critical to the success of this program. I've just been so thankful to so many community partners, inpatient people like Dr. Neely and Dr. Hill and Dr. Clayton and outpatient physician groups that have all opened their arms and really taken our residents in to do their training through here. And we've also been very lucky to have supportive administrations. Go figure that you have two CEOs talk to each other that might have strong opinions. So having to work through and teach both Lisa Davies, who is just a powerhouse of a CEO, has been such a community advocate for the vulnerable patients that we see at CHOP a Day, and Dr. Neely, who's had a lot of experience in graduate medical education in his prior work in Stockton. So them coming together have made it very possible for us. In this photo, part of the teaching and education, I was running into a little bit of some challenges in getting getting CHOP a Day to understand the value of a residency program. So I wrote a subaward to my grant and flew my C-suite from CHOP a Day to Port Angeles, Washington, to show them a similar clinic that we modeled ours afterwards. This picture is actually right on the U.S.-Canadian border in Port Angeles at an FQHC up there. And so I was really impressed by Lisa just taking the time to be willing to learn and fill some knowledge gaps so that she could support the program. And then, yeah, you want to talk a little bit about your experience with kind of teaching a clinic that's been naive to having residents in it?
So when we, as resident physicians, when we come up and are seeing patients, we're doing so under the mentorship of a faculty physician, such as Dr. Gukin. And so we see patients on our own, we come up with our own assessment, our own plan for the patient, and then we run that by our faculty mentors who say yay or nay on our plan, or sort of guide us in the right direction if necessary, and also are providing instruction on procedures and that sort of thing. So we've been really lucky to have excellent faculty mentors up here in the program, many of which were trained either at our urban site program at the Methodist program, or were trained at the University of California, Davis, and they've all provided sort of unique perspectives and have been excellent mentors for us. And we also have medical assistants that have been very helpful to our practice and and nurse practitioners that work at Chapaday who will pull us over if there's something that they believe would be a good teaching moment. So we've just had nothing but wonderful support across the board, both at Chapaday and at Sierra Nevada.
And so just some fun photos of all the engagement. We have regular meetings. The top left slide is a combination of our urban and rural faculty working together on some ultrasound teachings. We do regular faculty development to train our faculty up and keep them up to speed and train some of their faculty down there. Here's our community engagement with one of the urban residents doing our Walk with the Doc program that we do every third Wednesday, meeting at 7:30. And then you see us up in Port Angeles, and then our local obstetricians, Dr. Kittner and Dr. Jensen, joining us for some teachings in addiction medicine with our pregnant population. So I won't read through all this, but this is just kind of reviewing that we see this as a pipeline, or the updated way to talk about graduate medical education is a pathway model, because a pipe is theoretically closed and not open to bringing people on. So our pathway model to try to just have multiple outreaches to both medical students, residents, and then we have a new FMOB fellowship too with Methodist, that we have a resident who is has completed their residency program in family medicine and is doing an additional 1 year of obstetrical care to try to meet some of our rural and urban obstetrical gaps. And getting a little bit long there, but lastly, what I'll kind of end on is part of that pathway is we are embracing multiple partnerships with UC Davis. 3 of our faculty are now associate faculty member, volunteer faculty with UC Davis, and we are training both Rural Prime, this is their program in medical education, for medical students interested in working in rural areas. And then they have a new cohort called Tribal Prime, which is either American Indian, Alaskan Native medical students or students with a passion for serving that patient population. And our first rotation, we just finished our first year with Savannah Lukes, who's been doing her regular continuity clinic at Chapaday. She's part of the Sioux tribe, but really interested in learning more about treatment of her native peoples. So our next steps is that we hope that we will be graduating our first class on June 30th, 2026. I think Dr. Spar, likely, I think I'll graduate him. He's on track right now. He showed up today, so that's another check. And I hope that we'll be able to hire some of these grads to work in Nevada County. And so just our conclusion, I really see graduate medical education as a key for us to improve our workforce and meet some of these shortages. So hopefully when I come back in a few years and get an update and ask about who doesn't have a PCP, that there's a few less hands up in the room. All right, and thank you.
Can we see if some of our attendees would like to ask some questions? Yeah?
Yeah.
Any questions?
I've heard that one of the problems with keeping doctors in Nevada County was because so many people are on Medicare and Medicaid that it's difficult to keep the offices open and to pay the doctors properly. Is this true?
Absolutely a challenge for many practices. I practice in a group setting. I'm employed by a combination of the hospital and Chapaday, so I do not work as a private practice physician. Dr. Callahan came and introduced himself to me, and he worked in a time when much more of the practices up here were private. I worry that just with the nature of healthcare that the private practitioner is a dying breed. We have some amazing private practices up here that are still holding on and still delivering very high quality care. But it is a challenge that it seems like that area of medicine is changing. So part of our hope in training residents to work as employed physicians working for federally qualified health centers or group practices is that they'll be most comfortable and confident in that model. So if you ask me in 10 years, what will our health infrastructure look like up here, I worry that it will be mostly group practices. And there are problems with that, but if we can have access for our patients, that to me is the first priority. So trying to train our residents up for either practice, to be competent to practice either in a private setting or in a group or a corporate structure. But I do fear for kind of the future of some of my colleagues that really prefer to work as private practitioners.
More questions? I saw hands up over here. Lanny?
I was just wondering if the price of housing and rental is also an issue for bringing or for inviting people to stay here after their residency. If they've got a housing during the residency that has been offered, but then they have to find their own place.
Absolutely. You know, I think that's a problem for most, for many rural programs is just, is there enough space? Do you have housing inventory for residents to be able to get? We're not as desperate as some rural programs across the country, but prices are prohibitive, but I feel like we're competitive or even a little cheaper than a lot of the real popular urban markets in California, you know, San Francisco, Sacramento, Los Angeles, so that prices are reasonable compared to that. That is a concern for me, and we have an incentive that we've been able to offer because of the generosity of the community, that we are able to give the residents a housing stipend for the period when they move up. Because as Dr. Spar, maybe he can talk about it a little bit, but we worry about residents coming up and someone saying, well, I have a rental available in April, and then the residents working 2 months in a row in the ICU and you know, doing their 100 hours a week of training, that they have a hard time finding a place. And so we give them that housing stipend that they can either use it to invest in a property if that's if they have the ability, or to maybe if they have to put a 2 or 3 month deposit on a place because people don't want to leave something vacant for that time. So we're trying to address it in that. A bigger area that I have the most concern about is how we're going to keep partners happy. You know, is there employment and jobs for partners up here? And I noticed that in a lot of physicians that are recruited by the hospital, that the physician might be very interested in the community, but the significant other either isn't or is concerned about employment. Do you have a comment on housing and how it was for you?
So here.
Okay, who's next?
No, yeah, I would echo everything Glenn Gukin has said, but one of the things that the residency program does is that starting this July, every year you're going to have 4 new physicians in the community, living in the community. Their significant other will be living in the community, and it creates sort of inertia that makes it easier to stay in the community once you're established here. And so by the end of residency, it increases the likelihood, I would say, that those physicians who are training here remain here. And it's easier to retain those physicians than it is to recruit physicians who don't have any ties or don't have any exposure to the community.
Next question?
It's me. Okay. I have a question about part of what you said, Nick, during your presentation about the rotations. Since I'm not inside the medical community, 2-week rotations sound really brief in each specialty. So 2 parts. One, do you repeat the same specialties in year 2 that you had in the more urban setting in year 1? And the second part is when you're up here and you see patients, do you see any repeatedly so you get training in continuity of care, or is it more one and done ER kind of treatment?
Yeah, that's a good question. So first, the 2-week rotations are pretty brief. I would agree. I think that actually was a model that was developed during COVID when burnout was pretty high for those physicians training in the ICU during that period, and so they switched over to a 2-week model. That is 2 weeks on within a service, But then I will go back to that service several times over the year. And so, for example, when I was on obstetrics, I'll be on obstetrics delivering for 2 weeks, but I ended up doing a total of 8 weeks of obstetrics during my intern year, and then I continue doing at least 4 weeks, 8 weeks maybe of obstetrics second year. And so we end up going back multiple times. And to speak to your question about continuity, I do have patients that I see in clinic at Chapaday, and so for at least a half day every week, I will always be in clinic at Chapaday. Depending on the rotation, I may be over in my clinic Chapaday several times a week, and so I do see a lot of patient continuity there. Of course, because I'm rotating through different specialties up here in a small community, I do also sort of unintentionally see some patient continuity between services, and so I'll see patients in one setting and then I'll see them again in another setting, which is kind of fun, and seeing the different aspects or components of their healthcare in different settings has also sort of added value to our training.
Okay, more questions?
And I might add just one other thing to that, that the perspective also is we've received our training in our 4 years of medical school on a lot of these disease processes with longer rotations in medical school. And then when you're, so Nick has been trained on cardiology for the past first 4 years of medical school. Then in your intern year, when he's in the continuity clinic, we're still treating heart disease, diabetes, these things that he's being treating in the continuity clinic, trying to teach him to be as much of an independent practitioner as possible, only referring to Dr. Drew and Dr. Callahan when he really can't manage their blood pressure or their arrhythmia. But they're kind of mastering their craft at that point and getting subspecialty teaching on all of those different fields throughout their continuity clinic.
So I have a question about the rotations, but specifically, you mentioned OB, but I actually have a question that's broader than that, and that is full spectrum reproductive care. Unfortunately, we are pretty much monopolized by Dignity Health here, which is part of Common Spirit, which has Christian Catholic tenets that dictate what is allowed and what isn't. And so could you comment on how we can better provide full spectrum reproductive care, including abortion care, without having to send people down the hill?
Absolutely. And when I am not Catholic myself, and when my wife and I were interviewing at programs, that was our biggest turnoff to the Dignity Health program, was our concern about that. But absolutely. But what we were reassured is that our patients would have full access to birth control counseling, having the opportunity for sterilization if they choose. I've had 2 children and I'm confident I don't want another. I want to be able to have a tubal. It is a little more onerous within the health system. You have to submit a request 30 days prior, and emergency tubals are so emergency tubals are always covered, but if you didn't do that proactively it goes through someone within Dignity Health to review. I think maybe the nuns or something like that. I have to look into that directly. The sister, I forget her name. I haven't been down there for 8 years. But so you have to file that 30 days ahead, the petition to get paperwork in place about tubals. In regards to abortion care, that is a challenge and something that I wish that we provided at Chapaday. Right now we do not, as with our federal funding and with the tribal board statuses. So up here in the Grass Valley area, we only have the Citizens for Choice is the only option for abortion services for our patients. And so what we make sure is that as part of our terms of employment when we're interviewing, we have questions directly about that, because our expectation is if we hire a resident who does not believe in abortion care, that they are required to hand that patient off to another physician so that the patient can receive appropriate counseling and to have that service offered. So our residents do not have to administer those services, but if that's something that the patient is interested in, they have to be referred to somebody who will. So in regards to within the health system, I will likely not be able to have any progress on moving the needle there, but we're just trying to make sure we have good rotations and training for our residents at up here, Citizens for Choice down the hill at Planned Parenthood. And so we have electives for them, for residents that are interested in providing either medication-assisted abortions or therapeutic abortions. In emergent situations, the life of the woman is always first priority. I have not experienced a case like that in my 7 years up here at Sierra Nevada yet. I've not heard from the obstetricians that they've had any significant pushback in emergent care. So that's my only kind of update there. In regards to our full spectrum care, obstetrical care by family physicians is kind of a waning skill set. That's a little controversial in terms of a lot of residents don't see themselves providing those services, but we are still trying to make sure that our residents get that full spectrum care, and if interested, they can do the surgical fellowship, the one-year fellowship, to be able to provide, be an FM doc that does do C-sections. So Dr. Spar is not pursuing a route like that, but Dr. White is closely considering something like that.
My question, well, first of all, I want to thank you for creating this program and for you for being part of it. It's wonderful. We need it desperately. The first question was, how do you see treating patients in Nevada County? I realize you're specific to tribal and Medi-Cal type patients, as different from in the big city. That's the first question. Second question is, how do you deal with getting specialty care when it's really required for those people, since we have nil specialists in this county?
Perfect. I'm bogarting the mic, but I'll give a quick answer and then let Nick maybe give his perspective about some of his patients he's met in the first 8 months. What I've been most impressed by of the people of Nevada County is how resilient a lot of people are. You meet people from the city and how scared they are of wildfire or snow or ice or things like that. You just admire and appreciate the resilience of a lot of our county members. I do notice that there is a lot of kind of generational anger about loss of identity and loss of kind of their economic outlook. People that come out of logging families or mining families or things like that, and the loss of identity can be really hard to kind of address with them. But it has given us a good perspective, as opposed to working. Something my wife comments a lot about is we worked with a lot of first generation, either refugees or immigrant populations, and there was sometimes a little bit more gratitude from that patient population, and I notice that I think what some people mistake with some of our patients is some of the anger that we see there is not anger at the individual physician or nurse or anything like that, but just anger at that loss of whatever their prior path of employment was. And so I think sometimes that can take a little bit of time to understand until you get to work with them and then understand where those feelings are coming from. But I mean, some just really resilient, impressive people that are, wanting to get back out on their 30 acres and keep climbing up on the ladder on the roof when they're 80 years old and dizzy. And, you just kind of say, I introduced one patient to Dr. Spar the other day where I said, if there's a zombie apocalypse, we're going to that patient's ranch, so. Oh, and lastly, with subspecialty care, my hope, and there is evidence to support this, that subspecialists are more likely and easier to be recruited when you have a robust primary care infrastructure. So I'm not a urologist, I'm not a cardiologist, but the hope is if we build this high-quality graduate medical education program and improve our primary care network, that it'll make it easier to bring a lot of subspecialty care back.
I just wanted to add that one of the biggest strengths of this program is that we do training in an urban location prior to coming up here and training in a rural location. And so we get, I would say our residents in this program will get much better training than most other family medicine residency programs because you are learning not just from books, not just from your mentors that you have, of which we get double the mentorship between the urban and rural program, but you're also learning from your patients. And they're very different patient populations here versus in South Sacramento. In South Sacramento, I used the translation services. We had a translator on the phone. Ended up using 12 different languages to speak to my patients just in the first 6 months of residency. Up here, the challenges that I encounter most often are patients who haven't seen a doctor in 4 decades. There's a lot of that. And so those are very different approaches to patient care for those 2 different demographics. And I'd say that's an enormous strength of this program.
That's loud. So this program's relatively new, and you're taking like 2 each year. We don't know yet what the percentage of who's going to stay and who's going to leave, but let's say it's only 50%, so you get 1 new doctor a year. Are you looking at expanding this program, bringing in 8 people a year, so you have a better chance of retaining some doctors up here?
Short answer is yes. I'm looking to expand. We're looking to expand, and some of that's the negotiation with my C-suites in that area. The pros of the program and having the partnership with the Tribal Health Program and Common Spirit Dignity Health is the resources that come with Common Spirit and Dignity Health and the experience in graduate medical education, and then the benefits of having a really high quality tribal FQHC. But the con of that is having 2 bosses. And then I have the urban program. So I have 3 bosses. I have so many bosses that sometimes getting all the bosses to talk together and agree on the plan can make it a little challenging. So I aspire to, I hope to, and I think we have good reason why we should, but I don't have an exact answer on that yet.
I have 2 questions. One is the new administration is saying they may get rid of Obamacare, and a lot of our residents use it, and are you making any contingency plans? And the second is I've heard that bird flu is really concerning physicians, and I know it's not particular to our county, but would you address the anxiety some people are feeling about bird flu? So it's the elimination of possible elimination of Obamacare and possible bird flu pandemic.
Right. Absolutely. So I try to always, in an effort usually to diffuse situations, call it the Affordable Care Act, and that the ACA was also supposed to be repealed under our incoming president's prior administration, which didn't happen. So I'm optimistic, and we've not seen a clear plan. I mean, it's a beautiful plan, but we've not seen what the upcoming plan is going to be to replace it. So I don't anticipate that we will see large changes there. And for us, with our patient population, our Medi-Cal program with recent Medi-Cal expansions in January of 2024 have affirmed that every person who qualifies for Medi-Cal, regardless of immigration status, is covered in California. And California continues to fight for that. So we do not personally have a contingency plan within our program, but I'm optimistic that that will be protected because, so that's all I can say there. In regards to avian flu, our practice, we have something that was set up originally, kind of outgrew from Dr. Clayton's excellent efforts in the ICU during the pandemic, and we created a public health call that we've been doing every 2 weeks, Friday morning for the past 4 years, and a leader from every hospital and every practice in town gets on, and we have our public health officer going over updates in public health. So we were talking about either the COVID pandemic and now bird flu, and we get regular updates from Dr. Cook. So we are monitoring very closely. Dr. Spar and Dr. White have been trained up on how to screen for it. Anyone that meets the criteria for bird flu, we send a secondary confirmatory swab down to public health that is subtyped out to see if it is. I've only had 1 patient personally. Flu is really high right now. Influenza A is at high levels in our community. My daughter had mild symptoms last week, but she was vaccinated, so luckily didn't get very sick. But of influenza A, and we've not had a confirmed case in Nevada County. But all of the providers in the area have been trained on how to test for it appropriately. So for people who drink raw milk, who work directly with poultry or cows, or who have those animals on their property. So I feel like we have a very good plan in place about it. For me, surveillance is the big key because it's a virus, you know, that can mutate and can jump. And I feel like we're doing a really good job in the county of our surveillance on it. And we've had good success in the county of incorporating wastewater treatment screening that went into effect last year, and that was a positive outcome of the pandemic. So, yeah.
Hi.
And I apologize when I was shouting out. I just noticed Dr. Lesh here. I was giving all the shout outs to our male physicians, but I didn't see you sitting right there. So thank you, Dr. Lesh, for being here. She's awesome. She's taught me many things about Western Nevada County. Yeah, stand in. Let's give you
Right here. Oh, where's Dr. Lesh?
Isn't that Winnie right there? Or am I blind? Maybe I'm blind. Never mind. I thought that was Dr. Lesh. I apologize. Well, she's
Never
awesome
mind.
anyway.
Physician's assistants are integral to any practice or group here in Nevada County anyway. I don't know if that's true in other areas. So is there an effort to recruit, is there a companion program to recruit additional PAs? Because that seems to me that might be one way to handle the increase in patient need.
Absolutely. So APPs, advanced practice providers, physician extenders, we try not to utilize the language of mid-levels anymore because that's kind of, I don't like that term. I think it demeans our colleagues that do a really, really important job. So at different practices, so at Western Sierra, our other excellent FQHC in town, Polly Connolly has really championed the nurse practitioner training and hosts a lot of students. She was actually just awarded UC Davis's Nurse Educator of the Year, which was really awesome. So we have a couple of different groups in town that are doing rotations for nurse practitioners. We've hosted nurse practitioner on their rotations at Chappaday as well. So we participate in that regard. I'm not as active in kind of their training or development plan, but we do have multiple kind of leaders in the area that are contributing to that training up here. We do not have an NP or PA kind of residency or training like that in the county right now. So yes, we are, but we don't. I don't know of a dedicated plan kind of organized quite in the same way.
More questions? Oh.
My question is about community support. You've said how great the community support is. So the question is that primarily the foundation? Is it medical community, or is it community at large like us? And part two is, what can we as community members do to support this program and other like efforts?
Yeah, so the hospital board has been huge in bringing out different community members. Some of our biggest fundraising events that have been successful are things like the Starry Nights project that they do. When Starry Nights was put on hold during the pandemic, the very first kind of rejuvenation of it was the residency gala. So poor Nick and Kelty, I think, 6 weeks into your training, walked into the Miners Foundry to 200 or 300 people with their faces plastered all over the place. And we joked that it was probably the biggest party 2 new interns had had in the country. And that was just a really good example of how so philanthropy is very, very helpful. You know, it helps us when we try to address housing issues. And I would love us to have, you know, either a small apartment complex or something like that dedicated to trainees coming up here that we could have on a regular cadence that's either purchased by the hospital foundation or local members and rented out to the residents at a reasonable rate. Because they get a salary. I don't know if you call it fair or not, but they get a salary. And so if we could have kind of some dedicated housing for them, that would be an amazing dream in my mind. An easy way that I tell a lot of people is when you come across residents, as we have more of them coming in, to definitely not say no to having them see you. So if you get admitted to the hospital, if you see a cardiologist, an obstetrician, and they come in and ask, we have a resident physician with us, can they see you? say yes. You're getting, a lot of times, as high level of care, if not more. They're all trained at great medical schools, and all of their plans are being reviewed by the attending physician. So that's one area that the community can be extra helpful in. How else can the community support you?
No, I would say that's really important. I would really emphasize that when you're being seen by a resident physician, you're also being seen by that attending physician still, and they're spending a lot more time on your case than they might otherwise as they're going through it with me and finding all the teaching moments in your case. So I think you are likely getting better care by involving residents in your care. Yeah, yeah. No, I think the community has otherwise been very welcoming. I think our CMO, the Chief Medical Officer at Sierra Nevada, was joking with me that when he was an intern, he was assigned a number, and then he had to earn being called by his name. And our experience has been very different. He was joking, but you know, our experience has been very, very different. That we've been very welcomed by the community, and I think that's gone a long way in convincing us that this is the right community to train in.
Kim. Thank you so much for being here today. This is an amazing wealth of information. My concern is for dental and orthodontics and periodontal, is that the right word? And it seems to me that, well, gut health is like a household term now. We're all learning how much our gut health affects all of our systems. And it seems to me, you know, it starts with our mouth, right? And I worry that our senior community, and especially the underprivileged senior community, is the most challenged by having, you know, a healthy dental care. Do you ever see the two being under the same roof, where, because, you know, dental is so expensive, it requires a ton of cash. Will that ever be under the same house, so where the medical doctors will be part of initiating care for dental, and then just more affordable? It's a cash, horrible thing.
Great questions. I agree completely, and that's where you know, some of our models of our two federally qualified health centers of Western Sierra and Chappaday, they both have dental in-house, which is a great service for those patients that are able to be seen there. But for patients that are not eligible to be seen there, that becomes the real challenge. So I anticipate and hope that there'll be more kind of group practices in that model. I think a medical home model is the most successful, you know, where you have behavioral health, dental, and medical all under the same roof.
Vision.
What's that? And vision, yes. And so, you know, at Chappaday, we do have all of those services, and I think the high quality practices make recruitment easier. We do, at our practice, we, you know, we have monthly what we call mega meetings where medical and dental come together. In fact, last week we had a nice lecture about fluoride. Lots of people in this county have interesting opinions about fluoride. So I mean, we do a lot of that in-house, and to me, that's the gold standard of what we should be aspiring to. And yes, on that grant that we got to receive this, there are a couple of rural dental programs that have been funded nationally. So I would love if there's a dentist that gets fired up, and I'll help him write the grant, but I don't know.
Yeah.
That's about all I can do there. So.
Cool. Thank you. And for the audience, just want you to know Dr. Hill and Dr. Neely have a standing show on our news talk, one Monday a month, I believe, at 9 a.m. on Tom's show. They're the guests, and they talk about probably things that we're talking about today here. So.
But before we end it, Bernadette, I have one quick thing, okay? I'm going to preempt here. So this was an example on your purple sheet, in case you haven't filled it out, of robust question and answer. So for those of you that have been here before, sometimes we'll have a very long presentation and we'll squeeze in a few questions, but this was that much more open-ended, and we appreciate it very much because you guys are right on the hot seat. So thank you very much.
So is this helping you keep your 4-star status?
What's
Is
that?
this helping you keep your 4-star status?
Yeah,
Okay.
I hope so. We're aiming for the 5th now with you guys.
We should only get 3 because we brought the male resident. We should have brought Kelty. So.
No way. But what we're going to do is check back, because I can't wait to see what happens, and I know all of us are rooting for you to do well. So thank you.